three monitors which we commonly use are the blood pressure monitor, the CVP monitor, and the pulmonary artery catheter monitoring. Now, is blood pressure the ideal monitor? When we consider using blood pressure alone as a hemodynamic target, we have to think about a few things like technical issues. There should not be any proximal stenosis to the site of monitoring. The dampening should be optimal. You must understand that the arterial pressure waveform and mean arterial pressure will give you information on the hemodynamic status of the patient. But you must also realize that the intervention and the drugs to maintain blood pressure should cause more benefits than harm to the patient. And you have to understand the basic fact that in chronic hypertension, the cerebral autoregulation curve is shifted to the right and a higher mean arterial pressure is needed. Next, coming to CVP. Is CVP the best guide to fluid therapy? Now, with CVP, you do have mechanical complications of catheterization and infection. A CVP which is less than 5 millimeters of mercury may indicate fluid responsiveness. A CVP between 5 and 20 has very little predictive value for fluid responsiveness. A CVP greater than 20 in patients with right heart failure shows that the patient is fluid intolerant. You have to know that fluid responsiveness does not mean that this patient is hypovolemic. And some IV fluids do affect the coagulation system, and excessive fluid therapy can prolong mechanical ventilation. Now, coming to the pulmonary artery catheter. This was the gold standard of hemodynamic monitoring. This was till 1996 when Connors et al. Came with their observational study, and ever since that time there's been a decline in use of the pulmonary artery catheter. The present consensus is that the pulmonary artery catheter should not be routinely used as a primary means of advanced monitoring. So what are the modalities of advanced hemodynamic monitoring that are available to us? The pulmonary artery catheter. It is an invasive monitor. It is calibrated. The equipment consists of a thermistor tipped with a balloon catheter. It enables continuous cardiac output monitoring, right ventricular ejection fraction monitoring, RV pacing, and monitoring of your mixed venous oxygen saturation. The advantages of a PAC are it helps in direct pressure measurement of the right atrium and pulmonary circulation, and the oximetry variables are measured. What are the disadvantages of the PAC? It is invasive. You can have mechanical complications during insertion, infection, and arrhythmias. And even the continuous cardiac output monitor of PAC will average the cardiac output over a range of 5 minutes. So it's not really a real-time cardiac output monitor. And there can always be a misinterpretation of the tracing. The pulmonary artery catheter is ideal for patients with right ventricular failure or pulmonary hypertension, but it is not beneficial in patients with low-risk surgical patients. It is not useful in late-stage disease to guide resuscitation, and you cannot use the PCWP alone to help in volume expansion strategies. You'll have to look at the volumes also. The next monitor is the flow track or the Vigilio, which uses the pulse pressure and the pulse contour analysis. It is a minimally invasive monitor. It is non-calibrated. The equipment is you need a specific arterial kit for this. The advantage is it produces a good continuous cardiac output monitor which refreshes itself over every 20 seconds. It has good accuracy and is easy to implement and monitors the cardiac cycle efficiency. The disadvantage of this is this monitor needs further evaluation, especially in conditions where there is arrhythmias, or if you're going to use an intra-aortic balloon pump, these monitors are not validated. So is a patient with severe vasoconstriction where the values may be wrong.